I'm going to talk a little bit about cell-based therapies for ARDS. These are my conflicts of interest. I do collaborate with two companies that make stem cells, so that's important to bear in mind in regard to the talk. What are we trying to achieve with cell therapy? Well, the idea is that we would take cells, maybe like, as in this diagram, from the bone marrow. These would be mesenchymal stromal cells. And that we would use them allogeneically in patients. And by allogeneically, I mean we get them from the donor. They're not autologous. And MSCs are interesting that way because they don't have many of the class 1 or class 2 antigens, so you can give them allogeneically. So the idea is we have a donor, like our friend here, and that we would take their blood or their cord tissue or bone marrow. We'd process it in vitro. We'd have it ready in bags, frozen, ready to go for our critically ill patients. And that's what we're trying to accomplish, whether it's a cell or a cell product, whatever it might be. When we were initially, or when the field, I should say, was initially sort of thinking about using cell-based therapies, they were really thinking about stem cells. And by stem cells, I mean cells that make another of themselves or make a cell that goes on to become a differentiated cell. And one of the things we've learned over time actually is that stemness of these cells is actually not the most important thing. And we don't even, the cells we think about now, we don't even call them stem cells. So we say mesenchymal stromal cells because they don't have a lot of stem cell characteristics. And, you know, again, like the other speakers, there's reasonably good preclinical data and a reasonably good understanding of why mesenchymal stromal cells in particular might have therapeutic potential. This is work from our own group where we looked at a pneumonia model, like other investigators like Michael Mattei's group. And what we saw was that in a pneumonia, this was E. coli-induced pneumonia, that the cell therapy, when given shortly after induction of the pneumonia, reduced the pneumonia severity and improved the outcome. One of the things we saw was we thought that this would be anti-inflammatory, but what and it is, but one of the things we saw was that the bacterial counts were actually reduced in these animals. So there was something happening that was actually aiding the host immune response. And in this model, to John Daniel's point about antibiotics, this was an untreated model. No antibiotics in this model. We have repeated this with antibiotics, and we've seen the same thing, as in they still work in this setting of antibiotics. But what we saw was that there was a reduced amount of E. coli in these animals in the bronchoalveolar lavage, and also that there were increased antimicrobial peptides. So LL37, how does this work? And LL37, which is an antimicrobial peptide, was increased, and also the macrophage function was enhanced. So enhanced macrophage phagocytosis, enhanced killing. So this is not immunosuppression. This is modulating the immune response. And then people like Ger Curley and Sergio Grinstein looked at the specifics of the macrophage biology. And what they saw was that when you co-incubated macrophages with MSCs, they became both M1 and M2 type macrophages. And the M1 macrophages had enhanced bacterial killing. The M2 macrophages, which are more tissue repair, may be contributing to the enhanced repair effects you see in these models as well. And that brings me to another important mechanism. This is work by Michael Mattei and his colleagues at UCSF, who's done a huge amount of this work, where they were looking specifically at the repair characteristics of MSC. So they had a model of LPS-induced lung injury, and when they gave the MSCs, they had reduced injury and enhanced animal survival. Interestingly, when they gave lipoxin A4, which is a resolvin lipid mediator, they saw similar effects. And when they blocked the MSC production of lipoxin, they ablated the protective response in the repair. So these cells modulate inflammation, they enhance macrophage killing of bacteria, they enhance resolution of injury. And as we've heard from the earlier talks, these are the kinds of things we want to try to perturb and enhance if we're trying to treat people with ARDS. We've looked at what actually happens to the macrophage or to the MSCs when they're given to the animals intravenously, and basically they all go to the lung. Some of this might be hard to see now, but when you look at in a septic animal at 0, 2, and 24 hours, there are a lot more of the fluorescent MSCs in the septic lung. So the septic lung is retaining the MSCs. And when we look then at stained MSCs, what you see here on the right are the MSCs in the pulmonary capillaries. And in the bottom part, what you can see where the red arrows are little microvesicles that are budding off the MSC. So what we think is happening is the MSCs are trapped in the lung, they then bud off microvesicles, which then modulate or mediate the effects of the MSCs. This is work from my colleague in Galway, Dan O'Toole, along with Anya Krasnodermskaya at Queen's in Belfast. And what they did was they nebulized vesicles, so the small vessels or small particles that these cells make. So they nebulized them directly into the lung in the pneumonia model, and they basically saw the same effect. So we're able to just give them into the lung, just give the particles, not the whole cell, and we're seeing benefits. So one of the advances in the field in the last few years is there's been a significant move into the clinic. And so we've got quite a bit of clinical data now. This is data from Michael Mathey, who did sort of the key early studies, the START trial, and this is the second START trial. So this is the trial where they looked at in a 2-to-1 randomization cell therapy versus standard of care. And what they saw was no clear evidence of benefit, maybe a slight trend where if anything, the mortality signal was against MSC therapy, but nothing significant because these were pretty small numbers. But one of the interesting things they did find was that the condition of their cells, the viability of their cells was important. And in the patients that got the most viable cells, they had a signal that was more towards benefit. So that's one of the real challenges we have when we're studying MSCs, is it's a really difficult therapy to give to patients. This is some of the most encouraging data around cell therapies. This is the ARDS study, and this is a mesenchymal stromal cell precursor. So it's a proprietary product, and so they did a dose-finding study and then gave it in a 2-to-1 randomization to 20 patients versus 10 controls. Now they actually saw a signal for improved outcome. Now this is a phase 2 study, so anything in a phase 2 study has to be taken with significant caution. But there was clear evidence of an effect, and the effect was in the right direction. This is another study with the same cell, but they're looking at pneumonia-induced ARDS. And again, not powered for outcome, but the lines are the right way around. So there's a signal to suggest that patients who received these cells were more likely to survive. But again, a small study, not powered for outcome. And just like the other co-presenters, I'm going to now kill you with a meta-analysis. But this is an interesting meta-analysis. It's called a living meta-analysis, and it's done by the Canadian group in Ottawa. And what they've been doing is they're taking all of the COVID MSC trials as they're coming in, and they are analysing them. So they publish this about every 6 months. And so this is the one from sort of springtime of this year. And these were the trials that are reported to this point. So what you see is in the bottom arrow is the little black diamond is favouring the treatment. So there's an improved relative risk of death in the patients that got the cell therapy. And it's pretty close to the line, but it is the right side of the line. They also showed that hospital stay and CRP levels and index of inflammation were reduced by the cells, and they showed that they seemed to be safe and that there wasn't an increased risk of adverse events. However, the devil, as always, is in the detail. There was huge heterogeneity across the study, so different cell doses, different sources of cells, different timings. Some gave it once, some gave it 2 to 3 times. And the other big thing was that the standard of care was changing over time. So when these studies started, the standard of care was very different to what it is now. And I want to focus particularly on steroids. So in some of these studies, the patients got steroids, and some of them they didn't. And when you look back at the mortality signal, and you look at the ones that favour the experimental, these were in patients who did not get steroids, because that was not standard of care at that time. And when they gave steroids, the later studies that gave steroids, the signal is gone. Now, a treatment of mesenchymal stromal cells is about €30,000. A dose of dexamethasone is about $5 or euro. So they're going to need to do a bit better than be a really expensive steroid. This is an example of a study. This is the co-PIs in this were Danny McCauley and Cecilia O'Kane, who we've heard about already in the other talks. And they were doing a phase 2 study of the ARDS cell, which is, again, a proprietary cell that they were comparing to standard of care. They didn't see, and this was in steroid-treated patients, so they got the full sort of current management of COVID, and there was no clear evidence of benefit. They were safe, which was actually the primary outcome of the study, but no clear evidence of benefit. So where to from here? So this is an analysis of a pathway analysis from this study, the Realist COVID study I just showed you. What they showed was, just to make it clear from my level, is that they showed that the cells were doing something. So the cells were modulating gene expression. Certainly in relation to viral infection pathways, these were upregulated in both. But in things around senescence pathways, there was a clear increase in senescent pathways, which suggests they may be doing something to kind of resolve the immune response. So it's not that the cells didn't do anything, they did, but just, it didn't translate to an effect. We've seen variations of this slide area. This is the key study from Carlin and our colleagues. And the temptation is to propose that we should test hyperinflammatory ARDS for MSCs. Now, as Carlin has already said, and she said to me before, that's a dangerous assumption, because MSCs are not simply anti-inflammatory. They modulate the immune response. So it's entirely possible that they would improve the hypo-inflammatory. So what we need is a trial that actually stratifies based on whether you're hypo and hyper, and look at MSCs in both categories. So that's somewhere we may go in the future. Another thing is we may move to entirely artificial particles. The data so far, certainly the preclinical data, suggests that the particles have the same effect as the whole cell. This is data from cecal ligation and puncture, showing that MSC EVs that overexpress certain microRNAs are beneficial, and when you block them, they don't work. This is a very similar study with an entirely artificial nanoparticle in a CLP model affecting microRNA expression. So I think we may go there. You'd have a much more standardized approach, and it'd be much more like a drug than a cell therapy. We also have to be very cognizant of the environment within the lung and the timing around when we would give a cell therapy. This is data from Haibo Zhang and colleagues in Toronto, and what they showed here was that if you had a fibrotic lung microenvironment, which they replicated with the acid aspiration and ventilation-induced lung injury, the MSCs actually increased fibrosis and were not therapeutic. And so, whereas if it was not a fibrotic environment, it was either ventilator-induced lung injury alone, then there was a therapeutic effect. So we have to understand how the lung is responding in terms of the timing of the cells. And this is one of my last slides, but I have talked about mesenchymal stromal cells, but there's actually a really exciting area of research around T regulatory cells. So these are the adaptive immune response. We know that T regulatory cells are important in shutting off inflammation. They're a small population, but this is a clinical study where they use cryopreserved allogeneic T cells and showed safety. And so I think we're going to see more on these other cells. And I think there's a whole world of possibility around the T regulatory cell as a therapy. So to finish up, I think cell therapy has a lot of potential for ARDS. MSCs do seem to be safe, but they're not clearly shown yet to be effective. And there are other cells that I think, like Tregs, as I said, that we'll be looking at. We need ongoing preclinical translational studies. I think we've heard some discussion already about the challenges of the models. We need better models, and we need to understand the lung microenvironment and how it affects the response. It's actually really difficult to do these trials. It's a huge amount of really hard work, but we need to move towards standardizing doses and timing. We need to kind of agree on a strategy and try so we can meta-analyze, because at the moment we're kind of adding apples and oranges when we meta-analyze these trials. And I think, in terms of maximizing the potential of this therapy, this will always, I think, be a niche therapy. It'll be a very expensive therapy, and we need to identify the right patients. We need to identify the right time and test it, and we need to think about how we might modify these cells to optimize benefit. With that, I'll acknowledge the various people who've contributed to this work, and happy to take questions.
Caroline Calfee has a question.
John, that was a great talk, as always. What do you think about extracellular vesicles on their own as substitutes for MSCs? Do you think that's going to make it easier to do these trials? What do you think about efficacy?
So I think it will make it easier to do these trials if we just use the vesicles, because you are largely avoiding nuclear material when you do that. The challenges of making enough extracellular vesicles to do the trials is even bigger than for cells. But that said, there are trials of EVs that are in progress, and we'll know some results from those, I imagine, in the next couple of years. So that is a particularly, I think, promising area in the long term. And I think we may go entirely artificial in terms of the nanoparticles, and that would look a lot more than like a drug, and be easier to do.
John, I have two questions. One is very naive. How much data do we have on the cell survival once they are injected?
So that's a very good question, and the cells seem to break up once they're trapped in the lung, a good amount of them, and they end up in the reticuloendothelial system, and so it seems that that it is, it's the vesicles and stuff like that break off that have the therapeutic effect. When you go back at sort of 72 hours, even 72 hours in the animal models, you find very few cells in the animals, and there's very good data in patients who've had stem cell therapy where they look for MSCs, because there's some MSCs transplanted sometimes, and again they're very, very hard to find.
And the other question is, so if these studies are very hard to do, I believe they are, how about treatments? Do you think that from the logical standpoint, this is something that could be done in intensive care units, or should it be like CAR T cells reserved to a very few units?
So I think that's a great question, and I think we can take guidance from people who've been doing cell transplantation, because we call it cell therapy, but our hematology colleagues call this cell transplantation, and and I think you'd want to start in places that have hematopoietic stem cell transplantation facilities, so that you can kind of lever off that knowledge. But the ultimate aim and goal would be that you would have a therapy off the shelf that you could give to all patients.
It's a question around what happens if we try some of the things like steroids and other common interventions ex vivo on these cell subsets. Mechanistically, do they change, or functionally do they change? That's one question. Most of these are on DMSO suspensions, right? So once you thaw and recirculate, you might actually have less viability than you started off with. Have we thought about figuring out minimum viability or something that you need?
Thanks, Manu. So the first question around concomitant steroids and MSCs, I'm actually not aware that there's a study. That doesn't mean, of course, that there isn't. Just mean that I'm not aware of it. But there are studies like where and we've done some of them, and lots of other people have as well, where MSCs are given with antibiotic therapy. So you try to replicate the more, clinically relevant fluid resuscitation antibiotics, and they have an additive effect there. But in terms of steroids, I just don't know. I'm sorry.
DMSO question.
Oh yeah, DMSO. So yes, so the standard for DMSO is a preservative. It allows you to, when you freeze the cells, that they don't crack when you freeze them. And the standard is you put in 10% DMSO. And so so there's a debate around whether you should wash the cells or not before you give them in, or is it okay just to give them with the DMSO? If you wash the cells, it increases the fragility, and that then reduces your viability. And we think that you need a viability of 80% or greater. And so that's the target now in studies, is 80% or greater. And what people have been doing is they've been doing studies preclinical to look at reducing the amount of DMSO to try and get it down to a lower level so that, it's got less effects, risk for the patients. Yeah.
Thank you. I'd like to thank the 4 speakers for their quite insightful talks, my co-chair for sharing the podium with me, and you, the audience, for making this session quite interesting and enjoyable. Have a great Congress. Thank you very much.